The hypernatremia or increased sodium is when the sodium concentration is more than 145 millimoles per liter, and this may be due to increased sodium or decrease in water. So what are the causes of hypernatremia? Hypernatremia may be due to renal or extrarenal causes. The renal causes include diuretics and hyperglycemia and glycosuria in diabetes and central and nephrogenic diabetes insipidus. Rest of the causes are extrarenal and they include insensible loss from fever, high temperature, exposure to heat, exercise and burns, and the GIT loss, diarrhea and vomiting. It may also be due to decreased fluid intake as any defects in the osmoreceptors in the hypothalamus or due to psychogenic causes. And the last cause is excess sodium administration, oral or parenteral sodium administration or soda bicarb. Or it may be divided into polyuric or non-polyuric causes. The polyuric causes are the renal one and the non-polyuric are extrarenal. The polyuric then are divided into solute or osmotic diuresis and a non-polyuric, non-solute or pure water diuresis. The solute diuresis include diuretics, diabetes mellitus, uncontrolled mannitol, and soda bicarb, and sodium excess. The pure water diuresis or non-solitary diuresis include central and nephrogenic diabetes insipidus. So what's essential hypernatremia? Essential hypernatremia occur due to damage in the hypothalamic osmoreceptor that does not respond to forced water intake, leads to decreased vasopressin secretion and excretion of dilute urine. Hypernatremia may be caused by replacing sugar with salt in infant formula. It may also be caused by hyperaldosteronism or Conn syndrome. And how is the urine in renal and extrarenal causes? Urine osmolality is less than 700 milliosmoles per liter in renal causes, as in diuretics and diabetes, and if more than 700 milliosmoles per liter is extrahepatic fluid loss, skin and GIT. In a pure water loss renal form, it's less than 700 milliosmoles per liter, as in nephrogenic and central diabetes insipidus. And if it's more than 700 milliosmoles per liter, then it's due to hypodipsia, insensible loss from skin, primary hypodipsia or secondary hypodipsia. Majority of cases of hyponatremia are due to decreased water. Hypernatremia is usually mild unless there is abnormal thirst. So what are the conditions where there is abnormal thirst? As infants, physically handicapped, altered mental status, post-op intubation patient, and damage to the hypothalamic osmoreceptor. What are the effects of hypernatremia? Intracellular fluid contraction, extracellular fluid expansion. Why? Because the extracellular fluid, when hypertonic, it pulls the fluid out of the cell, and there is natriuresis. The effects of contracted intracellular fluid is that the most of the features are neurological, with an increased risk of subarachnoid and intracerebral hemorrhage, altered mental status, and neuromuscular irritability. So what's the response to hypernatremia? Increase intake of water due to increased production of vasopressin and a maximally concentrated minimal quantity of urine. The urine sodium is more than 100 millimoles per liter. A minimum of 600 milliosmoles per day must be excreted, and this can be done with a excretion of minimum of a 500 milliliter of urine per day. The maximal urine osmolality can reach up to 1200 milliosmoles per kg. So the renal water loss is the most common cause of hypernatremia and is due to drugs, osmotic and non-osmotic diuretics, and due to diabetes insipidus. And diarrhea is the most common gastrointestinal cause of hypernatremia. The osmotic diarrhea that occurs in malabsorption syndrome and viral gastroenteritis causes water loss more than sodium and potassium loss, whereas secretory diarrhea that occur in cholera, carcinoid, and VI pomas have sodium content of feces equal to that of plasma and present with normal or low sodium. So what's the renal response to hypernatremia? It depends on whether the hypernatremia is renal or extrarenal. If the cause of hypernatremia is extrarenal or administration of hypertonic sodium, then there is increased water intake due to increased vasopressin secretion that causes maximally concentrated minimal quantity of urine. The urine sodium is more than 100 millimoles per liter and urine osmolality is more than 100 milliosmol per kg, and it is done by a minimum excretion of 500 ml a day. Maximal urine osmolality can reach up to 1200 milliosmoles per kg. What does sodium excess causes? The sodium excess causes natriuresis with urine sodium of more than 100 milliliters per liter, and there is extracellular fluid volume expansion. Hypernatremia may also be associated with polyuria and submaximal urine osmolality. So what are the non-renal causes of fluid loss? The non-renal fluid loss may occur from gastrointestinal tract, respiratory system, skin, and from the third space accumulations. So how does the skin loss occur? Evaporative or insensitive loss of water is important in the regulation of core body temperature. Normal loss of water in the sweat is 500 ml a day, and the sodium concentration of sweat is 20 to 50 millimoles per liter. So what are the causes of fluid loss from the body? Fever, heat exposure, exercise, severe burns, and mechanically ventilated patients. The sodium concentration of the sweat decreases with profuse sweating due to action of the aldosterone. So the sweat becomes hypotonic. Since sweat is hypotonic, the water loss exceeds the sodium loss and is minimized by thirst. Hyperosmolality leads to intracellular fluid volume concentration. Hypernatremia leads to increased thirst and excretion of concentrated urine due to increased vasopressin secretion. Hyperventilation causes evaporative water loss, especially in mechanically ventilated febrile patients. The fluid in the GIT. There is 9 liters of fluid in the GIT, 2 liters comes from ingestion and 7 liters from GI secretions. And the fluid loss, fecal fluid loss is 150 to 200 ml a day. So what's the difference between the fluid loss in diarrhea and vomiting? The gastric secretion is acidic, so vomiting causes metabolic alkalosis, whereas biliary, pancreatic, and intestinal secretions are alkaline, so diarrhea causes metabolic acidosis. So what is the third space? Third space is the extracellular, but it's not in equilibrium with extracellular or intracellular fluid. The fluid is lost from the extracellular fluid and leads to hypovolemia. Example: bowel lumen in intestinal obstruction, retroperitoneal space in pancreatitis, subcutaneous tissues in burns, and peritoneal cavity in peritonitis. Will you differentiate between salt poisoning and hypernatremia of dehydration? In both salt poisoning and hypernatremia of dehydration, the urine osmolality is more than the serum osmolality. But in salt poisoning, the fractional excretion of sodium is more than 1%, whereas in hypernatremia of dehydration, the fractional excretion of sodium is less than 1%.